healthcare provider updates for Friday, July 24th. As previously mentioned, we have moved this update to a biweekly schedule for the summer from 1 to 2 p.m. So our next meeting will be in 2 weeks from today at the same time. And today we have a few speakers joining us to give an overview of where we are for our COVID-19 pandemic here in New York City, as well as an overview of epidemiological data. And we have other staff from the Health Department joining us, El Tante, Gender Justice Manager and LGBT Liaison for Race to Justice, as well as Ellen Weibel, Director of Research and Evaluation for our Housing Services Unit here in the Division of Disease Control. As a reminder, you have all been placed on mute, so if you would like to ask questions, please feel free to put them in the Q&A portion of the WebEx, and we will also be issuing a brief poll toward the end of the webinar in the last 5 minutes, and we sincerely appreciate your responses to that poll. It helps us to understand what type of content you're looking for. And with that, I will pass it off to Dr. Madhuri Ray to give an overview of the COVID situation here in New York City. Thank you.
Thanks, Allison. Can you advance the slide, please? So for our outline for today, welcome everyone. We're going to follow the same structure. As we mentioned, we are kind of data focused today, and then at the end I'll be giving you a quick clinical update on vitamin D, since we've had a few questions about that in the chat boxes. And so it just goes to show you that if you participate in the sorry about that. Can everyone hear me? Can people nod if they can hear me? Okay. Sorry, apologies. Yeah, just goes to show you that, you know, if you engage in the Q&A with us, then we are listening to you, and if you engage in the polling, then we're going to put that into our content. And I'm just going to ask Allison to advance the slide, please. We are on our update today. So we're up to over 15 million cases and 623,000 deaths worldwide due to COVID-19. As you're probably aware, and as we've been discussing on these webinars, cases are surging in many regions. Some areas are seeing second and third waves of infections. In some cases, the second and third waves are worse than the first. The daily case counts are increasing in much of the United States. And so as we have been seeing the last couple weeks, and perhaps it's getting even more extreme, we are seeing case counts really low in some areas, and we are seeing case counts getting very, very high to a level, you know, approaching and maybe exceeding what we've seen before and what we ourselves saw in New York City. So New York City is progressing. The case count remains low, and we'll hear a lot about that from our colleagues who are talking about the data today. But our case counts, but in New York City, our case counts remain low, and we are cautiously proceeding with reopening. We began phase 4 reopening on July 20th. And, you know, given the evidence and given the clinical picture across New York City and across New York State, we did not include indoor restaurants in that reopening. But again, case counts remain low. And to that point, and as you'll hear a little bit more about today with my other colleagues, we are closely monitoring the indicators of viral circulation in the community, and we are using those to really fine-tune the reopening guidance and to gauge the success of our continued suppression measures. And can you advance the slide, please? And so this is just a map illustrating not the total or cumulative, or I'm sorry, this is not the total or cumulative cases in the world by country. This is actually illustrating the change in the number of cases, of new cases in COVID-19. So this is, some countries may have, you'll notice that China, for example, is in about the same range. And while we know that China did experience many cases early on, that's no longer the case. And their transmission is very stable right now and pretty low. We can see, unfortunately, that in the United States and in Latin and South America, we have rising case counts. And so these are all areas of concern. And again, that's averaging the whole country as a whole. So as I said, we've got over 15 million cases, over 623,000 deaths. And can you advance the slide, please? And here we have the cumulative deaths and cases in the U.S. The top graph is a 7-day average of cases, and the bottom represents a 7-day average of deaths that's moving. So you can see that, the March and April time period, which was so impactful in New York City, we've actually exceeded that now on a national level. And the deaths, since we're seeing this is pretty recent, the deaths have not caught up to the number of cases yet, but it would not be surprising if the number of deaths increased in the coming weeks. Again, we have here the total number of deaths, cases and deaths in the U.S. That's over 4 million cases and over 143,000 deaths. And we can see, we've been looking in these webinars at the percentage of the total that's represented in the U.S. And as you can see in these curves, and what's indicative of a recent increase in cases, is that while we remain at a stable percentage from the previous webinar at 27% of confirmed cases, the percentage of reported global deaths has gone down, and we're down to 23. But again, keep an eye on that number in the coming weeks. And can you advance the slide, please? All right, and much like the worldwide curve that we showed in a previous slide, this is a county level map illustrating the change in the cases, so the recent cases. Again, you'll see, I'll point you to New York City and New York State, where initially, as we all remember, there were a lot of cases, but this is not a map of all the cases overall. This is a map of recent cases, and we can see that we're doing about the same. So we are stable here, but you can see that there are certainly other areas of the country in the south and edging into Texas and south, like the Midwest South and edging into Texas, where there is a rapid rise at the county level of the increase in cases. And can you advance the slide, please? And so now we have a couple of updates for you on some very quick updates on a couple of important clinical papers and clinical findings that came out. So we have a citation here at the bottom. I'm going to use this moment to remind you that the video of this talk and the slide will be available by Monday, hopefully over the weekend. But this is from a Morbidity and Mortality Weekly report, and it goes into, on the national level, characteristics of persons who died with COVID-19. And you will hear more about, the breakdown of deaths in New York City. And this is, keep this in mind as context for when my colleagues are discussing some of these demographic features and characteristics of COVID-19. And so in this study, this is all decedents, persons who passed away with laboratory-confirmed infection of COVID-19 between February and May of this year. And so the data sources just standardized COVID-19 case reports from 57 jurisdictions, but then it was also supplemented with data from 15 states and, of course, from New York City, because as you know, we have a very robust and we like to think transparent data collection system. And these characteristics of death are race and ethnicity, underlying medical conditions, clinical course, which is information about the progression of the disease, and where the persons died. And can you advance the slide, please? So these are just overall characteristics. This is the average characteristic of the persons who passed away. Again, you have to remember that, you know, averages can overlook if they're double, you know, if there are extremes at either end or there are extremes that cancel each other out. But you can see that the mean age was 78. We have spoken about age as an important risk factor for severe course of COVID-19, and of course the end point of that, which is death. We see a slight male predominance with 55%. And then overall, we are seeing numbers where the largest percentage of race and ethnicity reported was white, with Black and Hispanic Latino coming in right behind. And of course, this is just of everybody who died, what is the percentage breakdown? It's important to note that almost 1 in 5 of the decedents did not have race data listed. And can you advance the slide? So here we just have a graph that breaks down the race and ethnicity by age group, right? So we're looking at age and race in this graph. It's important to see that everyone under 65, because we have seen that age is such an important risk factor for severe disease. Everybody under 65 is lumped together. But you can see that, first of all, the age distribution amongst the deaths actually appears different in many of these groups. We have a lot of unknowns here. We have 665 persons of the over 10,000 that are unknown, and we don't have race information about them. But you can see in white non-Hispanic, the trend is that, just as we'd expect, you know, the number of deaths is progressing with the biggest number of deaths attributed to more advanced age. But we see a little bit of a different pattern here. We do see some deaths around in persons under 65, and then we see a little bit of a different pattern here with a bigger contribution to the deaths in younger persons. And can you advance the slide, please? And this is a similar curve where we're looking at underlying conditions, and we can try to, we can try to think about if there's a trend that, we can try to think about what we think the contributions of these two different pieces are. So what the contributions of underlying conditions versus the contribution of age. And again, overall, you can actually see that, a good percentage of people, 76% of people had at least one underlying condition, but a good portion at 31%, so that's almost a third, had more than 3 underlying conditions. And it's not very clear here, but it does look like, as people get older, you know, you can see the different distributions as they're parsed out here. You can see as people get older, there are slight differences in the percentages reported for the number of underlying conditions. And then, you know, the most common conditions that we are seeing as comorbidities in this report are cardiovascular disease at 61%. And I believe cardiovascular disease includes hypertension. Diabetes is highly prevalent, as we have discussed, and then chronic kidney disease and chronic lung disease make up the last two of the top four. Can you advance the slide, please? And this slide describes the clinical conditions associated with death. We can see some information here about the duration of illness with some variation across the age groups, right? You know, so we see, but they are very close, but we can see that for younger persons who do pass away from COVID, they appear to have been suffering from the disease longer. And then in the shortest period reported, it was 8 days for persons over 85. The hospitalization was documented for 84% of patients overall, but that number is actually decreased in persons 85 and older. And so that implies that those persons may have passed away not in a hospital. The highest percentage, however, of those who died in the emergency department or at home, meaning before they could get full hospital level care, was actually groups aged younger than 65 years. So a combined total of 8%. And then that actually decreased with decreasing age groups. So that means that, you know, the outside in the hospital, we are seeing older patients, but that doesn't necessarily mean that all patients who pass away from COVID are, you know, are representative of what we see in the hospital. And then the percentage who died in long-term care facilities did increase with increasing age and was highest among the persons who passed away who were over 85 years old. Can you advance the slide, please? Sorry, Allison, could you advance the slide, please? And then the study, you know, this study gives us maybe some insight and a piece of the picture of COVID-19, but it did have many limitations. The biggest thing, this is a convenience sample, so that means it's not representative. This is just all of the data that were reported, and we have to think about what data were not reported, like what data who didn't get a COVID-19 test, whose death was not recorded in this context. And in particular, the data on clinical outcomes and location of death is missing for a lot of the cases. And so, you know, when we don't know what's going on in a percentage of the cases, that means that the picture we're seeing and the distributions we're seeing may not reflect the actual distributions of the population. And, you know, given a lot of these limitations, statistical comparisons, such as calculation of rates, assessment of the interactions among factors, such as age, race, ethnicity, and underlying conditions weren't possible. And so, you know, we can look at it and try to guess at trends that we can spot, but we do have to remember that, you know, that those data are not reliable to make future decisions on. And can you advance the slide, please? So in summary, most people who passed away were over 65. Over 75% of them had at least one underlying medical condition. Important to note that the diabetes prevalence among residents under 65 was higher than reported previously among patients hospitalized with COVID-19, as we talked about in this webinar earlier, and of course the general population. And so that is, it's just implying, though again not concluding, that among people who are younger, right, if you are younger, that having diabetes could be a bigger contributing cause relative to people who are older. And then over a third of Hispanic descendants and nearly a third of non-white, non-Hispanic descendants were under 65, whereas only 13% of white descendants were under 65. So, you know, in younger patients, race seems to be a contributor, but again, we can't draw conclusions. And then among descendants aged under 65, 8% died in the ER at home, so not without full hospital level care. And so this could reflect a lack of healthcare access. It could reflect the fact that they didn't seek care. It could be a delay in diagnosis because of a perception on the part of providers that only older persons have severe COVID illness. And one lesson we can learn from that is that we should encourage patients, especially with those with underlying medical conditions, to seek medical care early and to really be aware of the symptoms of COVID. And I think as providers, you want to consider the possibility of severe disease among younger persons who are Hispanic, non-white, or have underlying medical conditions, and not to discount those persons as potentially having a severe course because they are young. So understanding the factors contributing to racial and ethnic mortality differences and out-of-hospital deaths could inform, again, even though these findings are not statistically significant and there are a lot of missing data, it could inform targeted community-level mortality prevention initiatives. And we'll go to the next slide, and I think with that, I will. Oh, sorry. I'm sorry. I've got one more. Another publication is the seroprevalence of antibodies to COVID-19. And so the confirmed COVID-19 test cases don't account for individuals who weren't tested. So if a person had contracted COVID-19, had mild symptoms, maybe didn't seek care, had limited access, didn't go to the doctor, even if they were ill, after recovery, they may never test positive for viral DNA for COVID. So to look at that, the CDC partnered with commercial labs at 10 U.S. sites to test for antibodies. This is testing on 16,025 de-identified blood specimens. So these were not just COVID specimens. These were specimens that were completely unrelated to COVID, such as routine blood work that you might get at a primary care visit. And they used an enzyme-linked immunoabsorbent assay, or an ELISA assay, to look for antibodies to the spike protein that the SARS-CoV-2 virus uses to enter cells. Then these data were used after age and sex adjustment to extrapolate the overall number of infections to said populations. And, this is the assumption that an antibody would be produced if a person did contract COVID and would be measurable in these blood specimens. The estimates were divided by the cumulative case counts that were reported to health departments, such as the New York City Health Department. And can you advance the slide, please? So this seroprevalence ranged from 1% in the San Francisco Bay Area. And, pay attention to the dates written here. So it's April 23rd to April 27th. And the high was 7% just under 7% in the New York City metropolitan area, and that was March 23rd to April 1st. So, of course, we're again going to discuss the limitations. So does this mean that 7% of New Yorkers had COVID? Well, I think we have to put that in context. So the samples that we got were, again, convenience, right? These were the blood samples that were in the lab. And so they are not representative of the population studied. We don't have information about factors like race, ethnicity, and occupation that might impact the way that we extrapolate the overall prevalence from the samples we did have. And of course, the results are preliminary. We're saying that it is likely that, if we look at the number of reported COVID-19 cases, at least within New York City, but probably in other places as well, that we can just have a working number of 10 times more infections than what was reported. Still, the percentage of people with antibodies everywhere, New York City included, is still relatively low when you think about it on a whole population level. And I think with that, I am going to give it over to my colleague, Dr. Thompson, who is going to give you an update on the recent epidemiology of COVID-19 in New York City.
All right. Thank you, Dr. Ray. We're just going to share our screen so that we'll be able to let Dr. Thompson give a quick data overview.
Great, thank you very much. My name is Corinne Thompson, and I'm one of the co-leads here. We serve at the Epidemiology and Data Unit here, and I'm part of the team that puts this data page together. So I'll go over a couple of updated points on our current data page, and then I'm going to tell you about some upcoming features that we're hoping to launch in the relatively near future. So, again, this is the data page, and for those of you who didn't hear me last time, just to also note that you can download the case data and also access some of our methods and technical notes on GitHub here, which has been a really great feature, so it allows people to take a look at the data themselves. And I was supposed to update this data 20 minutes ago, but I came here instead. So this will be updated shortly as soon as I go out. But anyway, you can take a quick look. So this is information by borough, and it's updated every day, and you can download this and take a look for yourself. Okay, so we are up to close to 220,000 known PCR positive cases in New York City, close to 56,000 hospitalizations, close to 19,000 confirmed deaths, and 4,600 probable deaths. The probable deaths were in an instance where someone did not have a PCR positive test but had COVID listed on the death certificate, and then a confirmed death is where we did have a laboratory confirmed PCR positive test. Looking at daily counts, we're holding steady. So this is again showing the entire time period. So you can see here in our peak weeks were the last week of March, first week of April, where we're seeing approximately 6,000 cases. This is the pattern you see here is related to weekend testing. So you see a really distinct 5 days of increased testing and then increased diagnoses, and then 2 days of lower case reports. And this is consistent across the country. We see people go to the doctor less frequently on weekends, and also some clinics are closed, especially on Sunday. But we have been holding steady at about 200 to 400 cases diagnosed per day over the last several weeks here. And we also have hospitalizations. Again, you can see the very dramatic peak in March to April, and then we've been holding steady at about 20 to 40 hospitalizations. This is by date of admission here. And then deaths, this is confirmed deaths only, obviously a lag between peak of cases, hospitalizations compared to deaths. And right now we're at about 15 to 30 reported deaths per day. This is, deaths by date of death per day. So this is by date of death here. So one of the things we're finding is there's a lot of confusion about report date and date of event. So we are always reporting information by date of event. So whether that's date of diagnosis, date of admission, or date of death, because when we use report date, which is the day that we report it out publicly, it's subject to data processing issues. Like, for example, there was one day where we had a number of several hundred deaths that came into our system in New York City residents who had actually died in New York State. And we had negotiated with New York State to try to get this information into our system. And so on one day, we reported out several hundred deaths, which is not to say that several hundred deaths occurred on that day, but were actually occurred back in time. So this is causing a lot of confusion. So last week, I think early this week, there was an article about how there were 0 deaths, and a lot of media sources, and that was very incorrect, because it not only does it take some days for us to find out about a death, typically, the increasing turnaround testing time, as you've probably realized, is especially for outpatient settings, is increasing. So at the moment, it's a median of about 2 days, but the 75th percentile of turnaround testing time from specimen collection date to report date is about 8 days now. And so when someone passes away, it can also take us some time to learn that they were even positive. Again, this is all cumulative data. So one of the things that we are hoping to put online shortly is a recent page. So we're hoping to put up here, we have our different tabs up here of different elements of our data. So we're hoping to have a recent page to get away from the kind of, you can call it stale, potentially, information that, since all of this information is from March 1st. But just to show what it looks like, if you haven't seen it before, this is case rates per 100,000 since March 1st. The darker the color, the higher the case rate. You can see Corona, Elmhurst, Jackson Heights has been consistently high throughout our epidemic. The Bronx also consistently very high. We also, just to show you, we have counts. We also have death rate. And then we're also using percent positivity, as I'm sure you're well aware, as a way of getting around access to test issues. One of the things that we watch very closely is emergency department visits, and you can see here, so this is obviously a leading indicator, so these are people with COVID-like illness, so they're not people that have been known to be diagnosed, but we did see, so this is the end of flu season here in February, and then right at the start of March is when we start to see a pretty clear signal. This is by age group here, and the dark line is rate overall, that's visits, and then we also have hospital admissions after the visit. So we're watching this very closely. ED utilization, as I'm sure you're mostly aware, is very low, although it is rising back up. So we will keep our eyes on this indicator very closely to see when the inevitable second wave arrives. And then this is daily testing. So again, this is citywide percent positivity over time, and we're very low, which has been great. We're at 1 or 2% every day. And we have our testing numbers as well. So the dark blue line is the number of people tested per day, and then the light blue line is the number of people positive. And you can see the lag here. So you're at about 30,000 tests every day on a weekday, but you can see the lag is pretty dramatic. So this is an underestimate, and it's from 10 days ago. So you can see that tomorrow this number will be much higher for the date 7/13. And then we do have, this is again all cumulative. We have information by the different demographic groups, which I think I went over last time. So if you want, you can come and peruse. Details on deaths. So when we first launched deaths, the difference between confirmed and probable deaths was a little bit challenging to explain. So we wanted to make a whole page about deaths. Although most of the deaths are now confirmed, but at the beginning there were certainly far more, as a proportion, more probable deaths as testing was so limited. And we're also very focused on trying to show as much inequity as we can, the noted disparities in our city. And this is race and ethnicity by age group here. Again, this is cumulative, but still very striking. Black, African American, and Hispanic, Latino New Yorkers suffer much greater rates of hospitalization and death. And then older, particularly older, well, actually at all age groups, but most notably in the elderly. And I believe the last thing I'll show here is our boroughs. We also, if you're interested, we also have all of the epi curves by borough. So if you want to take a closer look at a more granular level, we have information here. You can see Manhattan, the case numbers in Manhattan have been increasing slightly. We think that this is due to increased testing, but we are keeping a close eye on different areas of spatial temporal clustering in New York City. So keep your eyes out. We will hopefully, I hesitate to give a timeline, but hopefully we will be able to update our webpage soon with not only some recent testing, but also serology data. So stay tuned, and I'm happy to take questions. Thanks.
Great. Thank you very much, Dr. Thompson. We will look forward to taking questions at the end if we have time. We'll just go back to our PowerPoint and pass it off to El Tante. Whoops.
Great, you can advance. Oh, no worries.
Sorry, Al, one moment. Can you,
No
we
worries.
may have a technical difficulty with the screen share, so just thanks all for bearing with us. It should work. Nope. Sorry.
No problem.
That looks. This looks a little better, right? There you go.
Yeah. Great, thank you so much. So I'll introduce myself and then I'll ask my colleague to introduce herself. My name is El Tante. My pronouns are they, them, theirs, and I'm the Gender Justice Manager and LGBTQ+ liaison for the Health Department and the Race to Justice team in the Office of the Chief Operating Officer here at the New York City Health Department.
I'm Ellen Weiss-Deval. My pronouns are she, her, and hers, and I'm an epidemiologist and involved in some data alignment efforts around the agency as well.
We're both so grateful to be here. There are a lot of complicated issues as to why we're having difficulty getting better demographic data. However, you providers can help us in getting that necessary info. You are the backbone of healthcare in the city, and we're excited to discuss how we can all work together to get better data to support our communities. Next slide, please. So due to historical, institutional, and structural oppression, Black and Brown communities and lesbian, gay, bisexual, transgender, queer, and questioning, or LGBTQ+ people often experience more health disparities than their white, cisgender, and heterosexual counterparts in our city and across the nation, including higher rates of poverty, housing instability, homelessness, and job insecurity. All this has led to higher rates of chronic disease, which is a risk factor for COVID-19 complications. And as you've heard from Dr. Thompson, we've already seen high rates of COVID-19 among Black and Brown communities. Data collection systems have not been collecting standard demographic information, and some haven't used current identity terms, although it's getting better with our COVID-19 data, as you saw. Race ethnicity data collection isn't standardized across many jurisdictions and fields. Transgender, gender nonconforming, and non-binary people are often misidentified in data, resulting in exclusion from health surveillance and policy and program planning. Due to the lack of explicit sexual orientation questions also, data may also overreport respondents as heterosexual and misclassify lesbian, gay, bisexual, and queer people. Currently, we still lack important data necessary for mitigating marginalization in our COVID-19 health-related emergency response. Race and ethnicity data is missing for roughly half of reported COVID-19 cases nationwide. And most state and federal data lacks inclusive data collection, analysis, and reporting of sexual orientation and gender. Next slide, please.
So we are pushing for more inclusive and expansive data collections, but in a range of initiatives, and particularly for COVID right now. And part of this is because we know that in New York City, we have a really diverse population, and we want to be able to capture it in the data that we have. The U.S. Census Bureau tells us that 2/3 of New Yorkers are Hispanic or Latino or do not identify as white, and each of those groups has tremendous diversity within them, and yet when we ask our standard race and ethnicity questions, we may not be capturing all of that diversity. Additionally, there are over 700,000 LGBTQ+ New Yorkers, of whom about 50,000 may be transgender, and we want to make sure that we're illuminating the health trends of all of these populations. A lot of people identify in more nuanced ways than are captured in our standard race and ethnicity questions. And for example, I'm sorry, this is not from the Census Bureau, but from Health Department research, we've seen that many people volunteer additional information about their identities. For example, when they're asked if they're Hispanic or Latino, they may say yes, I'm Dominican, and we wanted to make sure that that kind of additional nuance is captured systematically. So the health department is now recommending systematic ascertainment of these data and is piloting new approaches in a range of our COVID-19 work. Next slide, please. So we've added new questions about race, ethnicity, gender identity, and sexual orientation to a range of data collection systems related to COVID-19. Interviewers who are asking and recording this information were trained about how to ask this information and how to address questions that might come up from respondents so that they can be confident about the terminology. These questions, which I'm about to show you and Ella is about to show you, are now being used currently in a range of COVID-19 data collection activities, including case investigations, contact tracing, and more. Next slide, please. So here are two of the 3 race and ethnicity questions that are being used in standard ways in the interviews that the health department is conducting and in other COVID-related data collection at the health department. The first is, do you identify as Hispanic, Latino, or Latina? The second is, which of the following races do you identify as? And it permits multiple responses. Both of these questions may look fairly familiar to you with some small adjustments. For example, we specify that South Asians, such as people from India, Pakistan, and Bangladesh, are included in the Asian response category. And we also specify by name some of the larger categories or identities of Black New Yorkers, such as African American and Afro-Caribbean. We also permit people to acknowledge that they do not identify as any of these races for any reason, including that they may be from a country where racial identities and the social construct of race may be different than that we have here in the United States and in New York City. Next slide, please. So we also have a third question, which may look quite unique to you, but really, again, is designed in a response to the way that New Yorkers were reporting their identities to the health department. The question is, which specific ethnic or cultural groups do you identify as, if any? You can choose more than one. And here we list a range of identities that New Yorkers may have. Some of them are racial or ethnic categories, others are a bit different, including Arab, Chinese, Dominican, etc. Another group or groups where I did not identify as any specific ethnic or cultural group. And so far, we have almost 3,000 interviews with these 3 questions with data, from about 3,000 COVID-related interviews done by the health department. And we've seen really good uptake in use of these questions. 87% of respondents reported a race or ethnicity in the first 2 questions that you mentioned. Of the 13% of respondents who did not report a race or ethnicity with those first 2 questions, this third question actually elicited additional identity information for 44% of people. So we see that we get much richer information actually for everybody, and perhaps especially for people who may not identify with the typical race and ethnicity categories that we often ask about when we ask all 3 questions. Also, we spoke with employees of agencies funded by the health department about what encouraged them about asking these types of questions. And many of them reported that they really appreciated the equity and inclusion that were reflected in these types of questions. They also appreciated that we were going to be updating terminology and appreciated that there was going to be general increased knowledge. Next slide.
Just as with race ethnicity data, gender identity data is also complicated and much more varied. So for gender identity data, there are actually 2 fields associated with it. Gender identity, which is how a person sees themselves, and sex assigned at birth, which is a designation made by a medical professional at birth and usually recorded on a birth certificate. However, those fields aren't always utilized by providers and other people who are collecting information. As an example, I wanted to show you information from a particular group of stakeholders that the health department works with. We work with clinical providers across the city through our Bureau of Equitable Health Systems and the Center for Health Equity and Community Wellness to better understand how those providers work and the support that they might need. In a survey of those providers, we found that there were major gaps in the utilization of expanded fields for sexual orientation and gender identity in their electronic medical records. So 13% of those practices actually use the sexual orientation field. 17% of those practices use the gender identity fields, and 19% of those practices use the sex assigned at birth fields. So that just shows an underutilization of those expanded fields, which gives us a lot of important information about the diverse communities here at in New York City. And whether or not your practice uses electronic medical records, gathering this data from your clients is an inclusive and expansive way to ensure that the best health outcomes for your clients, as well as for the larger community, are noted. Next slide, please. So these are COVID-19 questions that we're using, as Ellen said, in many different contexts for the response. And you'll see that we ask a specific gender identity question, as well as the sex assigned at birth question. And that is to ensure that we allow people to self-identify and affirm their identities while also being able to capture transgender experience. As I noted before, unfortunately, transgender, gender nonconforming, and non-binary people have historically experienced institutional, structural, and historical oppression that has exacerbated negative health outcomes for them. And so we want to make sure to capture that. And also we have probably a very typical sexual orientation question that you might be familiar with. Maybe queer and questioning might be additional responses that you haven't seen. And we just want to make sure that we are affirming very common identities that we've seen in our work with communities. Next slide, please. Often what we hear from providers is a reluctance in asking sexual orientation and gender identity questions, as well as sex assigned at birth, because they're worried that their clients won't feel comfortable in answering those questions. But actually, research has shown that clients will offer that information when asked, and in some cases even prefer being asked those questions so that their identities can be affirmed. First and foremost, we want to say that it's most important to create a welcoming environment for LGBTQ+ people in general in your practice. And that includes not just asking questions like this, but also ensuring that you post up the rights that they have. The LGBTQ Healthcare Bill of Rights is something that you can find on the Department of Health website, as well as having all gender restrooms and other things that would make it a welcoming environment for folks. Specifically about the questions and asking them in a way that feels affirming and comfortable for clients. You can actually see this in the LGBTQ Medical Association recommendations, but it's important to routinely ask about all three categories, so sexual orientation, gender identity, and sex assigned at birth when you are doing your intakes with the clients. When possible, use open-ended questions to allow people to self-identify. Ask sexual orientation or gender identity questions during the social or sexual history portion of the patient interview, as it seems to flow a little better in that conversation. And make sure that you're only asking necessary or relevant questions to the care of the client. We see these questions as being necessary because they help us better understand the health outcomes for that particular community. And make sure that you normalize this practice across all clients. And if people ask that, you can say that this is something that you do ask all of your patients. Next slide, please. So thank you so much for listening to our presentation. The support that we could use from our providers, our provider partners, is to promote inclusive data collection as an important issue with your funders, with your labs, and to other agencies. We also ask that you use more inclusive questions and terminology for race and ethnicity, sexual orientation, gender identity, and sex assigned at birth, as this is a major step in ending health disparities as a city. When you notice trends with your patients, make sure to call us at the provider access line that you see above. It's really important to make sure that if you notice any issues or trends that we normally wouldn't see, to let us know. And if you would like to learn more about health equity in relation to this, check out our Dear Colleague newsletter from June. Thank you so much.
Hi all, it's Dr. Ray. I'm back again to thank you for that excellent presentation. I found it really useful and learned a lot from it. We're just gonna give you the quick clinical update on vitamin D you've been asking for in the next 5 minutes. You know, we've heard a lot. I really want to reference the data that we showed in the beginning from the health department website and Dr. Thompson's excellent review. And I want you to keep all of those in mind, all those pieces in mind as we talk about vitamin D. And I think part of the reason vitamin D keeps coming up is that vitamin D is really associated with a lot of things, a lot of patterns that we've noticed. It co-occurs with a lot of patterns that we've noticed around COVID-19. So, you know, we talked about age, and as persons get older, there's a higher prevalence of vitamin D insufficiency. We talked about race, and we'll get to that later in the presentation. And so the question is, does vitamin D insufficiency have a relationship to COVID-19? And what do we do about the knowledge we have right now? And this is just a quick reminder, and this will come up later in the presentation, but these are all sources. This lovely graphic is all sources of vitamin D. The biggest one in the center here is the sun, and I'm not going to give you guys a review of that chart with all the different forms of vitamin D and where they are in your body. I'm sure the providers out there remember that from medical school. Yeah, so if we could just go next. Again, I'm going to try to make this short and sweet to answer your questions. So why would we even think that vitamin D has a relationship to COVID-19 or the severity of COVID-19 or the outcomes of persons who might be exposed to COVID-19? So vitamin D insufficiency has been linked to acute respiratory infections in observational studies. And we have some of those studies listed at the bottom. Again, the slides and the video of this presentation will be available later on our website. But acute, you know, specifically with acute respiratory infections, both those who have severe acute respiratory infections, flu is a particular disease where we have noticed vitamin D insufficiency related to severity of disease. It's also related to deaths. You know, there's a co-prevalence if you look at the vitamin D levels of persons who pass away, of persons who have severe flu. So why would that happen? Vitamin D is very active in the lungs, and of course, acute respiratory infections all have in common that there is an impact on the lungs. Vitamin D, you know, maybe this is going to be the one webinar where I didn't talk about how everything is related to the immune system, but actually that's not the case. Vitamin D is a well-known modulator of both innate and adaptive immune responses. Innate being you know, for example, when you cut yourself, but really a general non-specific immune response to any foreign body or foreign agent. And then an adaptive immune response is what we see with vaccines, and that's specific immunity to an infectious agent. And then suppression of the cytokine response. So part of this modulation is that there is a relationship there appears to be a relationship between vitamin D and specific cytokine production. And as you may recall, many of the proposed therapies for COVID-19 and many treatment algorithms are contingent on the level of the cytokine IL-6. And there does appear to be a relationship between vitamin D insufficiency and cytokine, production of IL-6, overproduction of IL-6. So what does that mean? And so, some studies have suggested a role of just giving out vitamin D to everyone in order to prevent respiratory illness, or as a widespread vitamin D supplementation for flu, for other colds, etc. And there doesn't really seem to be evidence that supplementation of vitamin D over the level of correcting insufficiency, so excess vitamin D, is helpful at all in respiratory illness prevention. Next slide. So, all right, so we understand how vitamin D might be related to respiratory infections in general. What about COVID-19 specifically? And I have a map here, which actually shows that the level of sun exposure, I brought it up and I'm bringing it back right now, the level of sun exposure is related to vitamin D insufficiency. And so you can see that in areas around the equator, there is a different level of vitamin D than in colder areas such as North America. And early in the response, or early in the pandemic, there was when Europe and when areas in China were experiencing severe vitamin D and other countries were not, there was an idea that the latitude you lived at, so might have some relation to COVID-19. And of course, in areas where you're farther from the equator, where there is less sun exposure, persons do have vitamin D insufficiency, is more prevalent. Of course, I just showed you a map today that showed areas around the equator in South America experiencing a rapid resurgence of cases. So that initial observation that led to that hypothesis doesn't really appear to be correct. There are some observational studies that have indicated that, especially I think in Indonesia, which does have a lot of sun exposure, they found that the patients with COVID actually had lower vitamin D levels, or with severe COVID had lower vitamin D levels than patients who had mild COVID. But I think that the recent caseload is not really compelling for that hypothesis. I mentioned earlier that there is a co-prevalence, right, of vitamin D insufficiency with a lot of these factors that we think contribute to the severity of COVID-19, and I listed out here older adults, persons who are obese, persons with diabetes. I don't have listed here race, but we'll get to that in a second. Vitamin D insufficiency is common among patients with severe COVID-19. It's also common among people who are very ill. And it's correlated with poorer outcomes in vitamin D insufficiency is correlated with poorer outcomes of COVID in a few studies. But again, it's really unclear what is causing what. Is the illness causing low vitamin D levels? Is low vitamin D causing the illness? And in terms of these hypotheses that we're exploring, I'm pointing out a study of 500,000 UK biobank participants. So this is similar to the Sero survey we talked about earlier, where they just looked at samples that they had collected on COVID-19 patients for other reasons and tested them for vitamin D levels. And they were really looking in this study they were really trying to parse out vitamin D and race. Of course, Persons with darker skin absorb less of the vitamin D from the sun. And so persons with darker skin often have higher prevalences of vitamin D insufficiency. But they did really actively look at race here, even though it was not like an prospectively collected sample, but they did not find any difference in outcome based on vitamin D level that they could separate just from the race outcome. So it does look like race is not just an after effect of vitamin D insufficiency. Next slide. Sorry, and I'm going late. So what does that mean? What do we do? What does the provider do? So we just want to say that we don't know what's causing what here. We know that often patients who get really sick from COVID have vitamin D insufficiency. So it's reasonable to pay a lot of attention to treating vitamin D insufficiency, right? The flip side is that there's no evidence that extra vitamin D on top of what you need to get to a normal level of vitamin D is helpful at all. And in fact, there are cases where excess vitamin D can be toxic. There are a couple papers that we have at the end where, that are sort of rapid supplementation schedules if you do have a patient with COVID or who is at high risk of exposure to COVID and vitamin D insufficiency. And then the next slide, please. So this is just, for me, just the reference levels, common reference levels of vitamin D, because I always forget them, and just a supplementation algorithm for all of the providers on the line to look at, again, mostly because for me, I forget how to treat vitamin D deficiency very often, and I like to have a reference. And I think that's all we have, and I apologize for going a couple minutes over. I think we'll probably...
Thank you, Dr. Ray.
Thanks.
And to all of our presenters for all that wonderful information today, and thank you for our attendees for sticking with us a few minutes over time, as well as for addressing some of your questions in the Q&A portion of the WebEx. I hope that you were able to see some of the responses to those questions. Unfortunately, we're out of time for any further questions, but just to remind you that we will be posting the slides and a recording of this webinar on our website, so you can find it there hopefully by tomorrow afternoon. And then our next provider webinar will be on Friday, August 7th from 1 to 2 p.m. and we will be updating our website and sending out information about that via email soon. Thank you again for joining us and enjoy the rest of your afternoon.